Okay, great. So I think we're getting the cue to get started. 10:07, so a few minutes past 10:05. So first off, I'd like to welcome everybody here today. My name is Stephanie Hemrick. I use she, her pronouns. I'm with Seaway Valley Community Health Center in Cornwall, and I'm the manager of community programs. I think I just said that. And I'm here with my co-facilitator, Chantal La Jeunesse, and she is our social worker and MSW, and she'll also be co-presenting. So we're very excited to be here today as we're actively involved in social prescribing, but we have a bit of a different model that we're pretty excited to share with you about. If people want to pop questions in the chat, Chantal and I will be monitoring it throughout the presentation, or feel free to raise a hand or jump in if you want to at any point. So the topic of our presentation here today is social prescribing without a link worker, bridges an interdisciplinary and sustainable social prescribing model, with a question mark because we're exploring that. So to start off, I would like to start with a land acknowledgement. So as I mentioned, I am joining from Cornwall, Ontario, on Turtle Island. And to take this moment, I wanted to before our meeting officially begins, I wanted to take a moment to acknowledge where we stand today is the traditional territory of the Haudenosaunee, Akwesasne Mohawk, and Huron-Wendat people since the time. As Canadians, we are forever grateful to those who had been on these lands before us and through stewardship and connection to the land have made it what it is now. So as a way to acknowledge these lands in a way that feels meaningful, I'd like to welcome a moment of gratitude into our acknowledgement. So please join me taking a moment to reflect and think about a time that you felt gratitude for your connection towards our land. I can share that, that where we're situated, we have the St. Lawrence River. I feel very connected to it. I'm often running by it, and I'm often reminded of the gratitude I have as a settler. While we reflect on our personal connection to these lands, let us all offer gratitude to those who share their traditional territories with us. Recognize the privilege we have in calling this our home and the responsibility we have in reconciliation as occupants of this Indigenous land. I can also share that for myself, I'm a mother and I have two children aged 8 and 10, and part of my commitment towards reconciliation is to ensure that they are made aware of the real history. And even though this can be uncomfortable for them, because I didn't have that opportunity to even really understand the real history of Canada. So making sure that I can change that with this next generation, at least do my part in that. So the next slide is just a session overview. So I'm going to speak just a little bit about Seaway Valley Community Health Center, some of the complexity of our clients, just because it is quite relevant, the overview of social prescribing, our bridges model, some of the key components, advantages and challenges of the bridges model, and then a question and answer. So Seaway Valley Community Health Center is, for those that are from the CHC sector, it is a newer community health center, so became operational in 2010. So our mission is working with you for a healthier community, and our vision is really health and well-being for everybody in our community. Our values and principles are very aligned with the model of health and well-being, which is supported by the Alliance for Healthier Community, anti-oppressive, anti-racist, it's culturally safe. And we have that list. So just to show what we're kind of the organization that we're grounded in these values. So we do have, I know that folks have seen different iterations of this diagram, but that we really do look around equity and trying to really remove barriers as much as possible or lift people up. We also provide, additional resources to those who need it most. So it's a big part of the work that we do. With the focus on some of our clients, which I'll share in a second. So our target populations are really around we have the general population without a primary care provider, but really focusing on individuals and families who may have a low income, older adults, newcomers to Canada. We also see quite a few, and newcomers to Canada as well, as our community has recently seen an influx of asylum seekers. So that has recently been a big part of our work. As well as we do serve the LGBT population, LGBTQ2SQ plus population. Most of our funding is by the Ministry of Health. We do have small pockets of other funding, but almost 100% from Ontario Health. We have an interprofessional team. We're close to about 40 staff for other health centers, so not a very big center, but not tiny either. And just a few things that are relevant about the center is that I spoke about how we support families and individuals who may be living with a low income. So about 45% of our clients have a family income of less than $25,000 a year. So we do know, and this data needs to be refreshed as well. So we do know that many of our clients have significant challenges. And this has only been more punctuated in the last few years with the issues around food security and housing, and within social prescribing as well. I think it's very relevant because the additional support that we sometimes need to give our clients because of the financial barriers, and also the sometimes whenever we're trying to do social prescribing, the immediate needs that may come up above. So, you're trying to ask someone what matters to them, and the need may actually be housing or food. So making sure that we're addressing those causes as well. So very relevant for our work. I'm going to let Chantal speak a little bit about some of the complexity of our clients.
Thank you, Stephanie. We just move to the next slide. Thank you. Okay, so our complexity of our clients may be different than what other agencies provide or service. So for us within the CHC sector, we have something called the SAMI score. And the SAMI score is used to measure complexity of clients. And within us here at Seaway Valley Community Health Center, our SAMI score is 2.9, which means that if an average Ontarian is set to 1, we are 2.19 times that in terms of complexity. So as you can see, that really increases the level of time and resources and energy needed to support these clients. And to add to that as well, our SAMI score is actually the highest compared to all other CHCs in the Champlain region. So as you can see, we do need social prescribing and bridges to really help the clientele. And that's why we're so happy to present what bridges is to all of you today. Next slide. So again, this is just a picture depicting what I just mentioned. And next slide again. Okay, so what is social prescribing? Essentially, social prescribing, it's an approach where we consider both the social and medical realm in healthcare that brings it together so that we work together to meet the needs of the client and or families. So it's a pathway for healthcare providers to address the diverse determinants of health, which we all know can be income, education, access to food, access to medication, those sorts of things, using the familiar, trusted process of writing a prescription, which most healthcare providers in the medical field are comfortable with. Okay, and if there's any questions, feel free to add in the chat. So the reason why we feel that social prescribing is so important, just with Seaway Valley itself, with our high complexity of clients, is that 80% of individuals' health is related to social determinants of health, as many of you likely know, and 47% of adults, disconnected older adults, rate themselves as less healthy overall. All the more reason to address these concerns with the client, not just the medical piece, but also the social piece. And mental health is included in that as well. I believe here there's some questions in the chat. Kelly asked, are we able to get a copy of your SAMI? And Sana says that she's interested in how the SAMI score is calculated. Steph, I'll let you answer that one.
Great. So this is actually, so the SAMI, and I wish I had a definition. I know that there's people on this that can probably pop it into the chat. And whenever Chantal and I do a switch over, I can give you a bit more links. So the SAMI score is it's a calculation of like we said, the level of complexity. So some of the data that's calculated to do this is actually whenever a client is at our center and whenever they come in for an appointment, it's some of the issues that are present. So some of their problems, so their conditions that they may have. So a complex diabetic client, for example, is weighted heavier than a non-complex client. So the heavier that a client has, so the more comorbidities a client have, the higher the SAMI score. Things like social isolation may also impact. So this is all done through our EMR whenever we chart in our EMR. The other piece that's done is it actually takes aggregate data, or not aggregate data, but it takes data on the client around hospital visits, specialist visits, and then it gives us a number kind of globally. So we don't get SAMI scores for you're not going to know this client in particular is this much more complex. You won't necessarily know that. It's usually reported at a center level. And what we also know is that, and this is because we offer primary care services. So this is how they're able to calculate it, because we have a doctors and nurse practitioners that are involved in nursing, and they're doing active charting. And then that data is able to be mined, I think is the proper word, through some business intelligence tools to then provide that score. And this is updated every few years. I don't know if that is helpful or clarifies. If you Google SAMI, S-A-M-I, and then you put Johns Hopkins University beside it, or even Alliance for Healthier Communities, you'll get a bit more data on it as well. We don't do too much except we just chart, and then we get a report on what our data looks like. So, but it has really reinforced the value of good charting and making sure that we're really clear on those encodes for the clients so that we can really get the resources necessary. The other impact for those that work in a community health center is that the number of clients that our primary care providers need to see is also proportionate to that SAMI score. So if the clients are more complex, we don't have to we don't take on as many because we know that they require more care. So that's the other piece, so we can better support our clients. Sorry, I can talk a lot, so I'm just going to have to, yeah. Does your CLAR include full social determinants of health, education, finance, and housing? So we try as best as possible to make sure that those are included in the chart. It's always a challenge, but what's nice is that because we work on a common electronic medical record throughout the building, like even Chantal's a social worker, and she would be charting those same pieces. So we try to, as much as possible, keep that information in the chart. Yeah. But
it's also in our demographics as well.
Yeah, the demographics on race and ethnicity, gender identity, social sexual orientation. So we do really work on that. It's not perfect, but we're definitely something that we're working towards. Okay, I'm going to show you a little video about social prescribing. I think that most of you may have seen a little introduction to this. But this is one that was specific to our center.
One of the factors that determine the outcome of health and well-being is the social determinants of health. So social prescribing is something to help clients to fulfill their health and well-being goal in a holistic way. So it's essentially, bridging the medical care and the social care.
Social prescribing here at Seaway Valley is really, instead of looking at what the problem is, it's really looking at what clients' strengths are. So really asking the question around what matters to you versus what's the matter. Another referral that looks like we have different walking programs. We have a snowshoeing program that operates in the winter. We have exercise classes for older adults. How's everyone doing?
My daughter suggested I come to one of the courses that they were giving was on COPD and asthma because that's what I have. I ended up meeting new friends and everything, and I've joined more classes, and I find it's very rewarding. All the courses that I've taken have changed my life quite a bit, like how to control it whenever there's stress in my life or pain, chronic pain. I've also learned healthy eating, which is great because I've lost over 100 pounds in 4 years. The staff here is great. You can be yourself and have fun, and they don't judge you.
So what kind of things do you think that we can offer in the community for food insecurity?
Link them to our community garden if they want to come in, and there's always free pickings for anyone in need.
Why did I volunteer? Well, it's sort of all because of the Heart Institute. I went for stents and triple bypass and that, and every time I went, there was the cardiac rehab center. So I said, well, maybe I could volunteer. I love to drive people around, and especially some of the seniors. I know I'm a senior, but some of the seniors, they can't go out much. A lot of the people feel a lot better after they leave, and they're able to talk to different people, get different insights, and not feel alone.
I'm seeing a huge impact of social prescribing in my clients. Their need to access care, especially in a ER setting or in a hospital setting, is much reduced because their needs are addressed, not just their physical health needs, but their social needs are met as well. It goes to show how holistic care can sort of improve outcome, not just for the patient, but for the healthcare system as well.
There's so much value in having social prescribing and a funded position to help advance this work, because if you're a solo physician or nurse practitioner in an office and you're trying to do this work, it can be really difficult without a team around you.
Collaboration and good teamwork is very important to implement the plan. Social prescribing should be incorporated in day-to-day clinical practice. Of course, we want to address the issues in front of us around, what's physically wrong with someone, but I think it really is looking at what matters to them, because we know when the evidence is there and the research demonstrates someone having self-worth, feeling connected, that sense of belonging. There's just so much value to that.
I praise this place like crazy. I'd suggest anybody come to this place, they'll help you.
This is what Seaway Valley Community Health Center has to offer. This program will help you. That program will help you. Try it out.
Great. So that's a little video that was done. The Alliance helped support us with a video around some of the social prescribing work at Seaway Valley. You may not have been able to hear the music in the background, which would be too bad because it does add a bit, is what my coworker may have told me. So hopefully you were able to hear that. But I'm going to head over back to Chantal for the next slide.
Thank you, Stephanie. So I just thought I'd throw out a question here, and if anyone can just either share through the mic or even in the chat who they think would be actively involved in a social prescribing process. If we can just throw it out there. I'd love to see your answers. Primary care providers, yes. Clients, clinicians, link workers. Recreation therapists, allied health professionals, community programmers, clients, clubs and groups, yes. Community organizations, community navigators. These are all really great answers. Thank you. Formal supports of clients, physiotherapists, families and caregivers. I love all these answers. Thank you. So it seems like a lot of you really do have an idea of everyone who could be included in the social prescribing process. For us at Seaway Valley, it can include anyone from an admin person to volunteer to a client, like you said, and any of our other staff that we have here, including outside agencies as well. It really is a teamwork approach, and it's very helpful to work all together and have that constant communication, and which we'll talk about more in our Bridges format. So thank you everybody for sharing. Next slide, Stephanie. So how does social prescribing work here at Seaway Valley? So the first thing that we would do is a healthcare worker, and this also, like we mentioned, could be somebody working at the front reception, sees a need and refers a client to either a link worker or, in our case, more so Bridges at this time. So we have an internal process in our EMR, and they could add it right in there, or they could call up anybody who's on the Bridges team and say, hey, I want to refer to Bridges. This is what's going on. What can I do? And so they're welcome to do that as well. The second step is that the link worker or Bridges connects with the individual to understand their needs and interests. So actually what happens is that we discuss it together on a weekly basis. Generally it's every Wednesday mornings for us. And we discuss we brainstorm what we can best do for that client. And we try to understand a little bit more of what their needs are in that process. Then somebody will connect with them and provide community programs and supports, and we'll follow up to ensure that they have been able to connect and it was a positive experience for them. Okay, so traditional social prescribing, we made a little graph here, and essentially it's very similar to what we have already discussed. The difference is that for us, instead of having the link worker, is where we have our weekly meeting, where we consult about what's going on, what are the needs, and not just for clients as well as for staff. So sometimes staff will come to us, other staff will say, I have this client's keeping me up at night. I don't know what to do. Can you please help me? And so we'll provide any support we can in that setting. Also with that, sorry, go back, Steph, is that when we refer internally, we're also able to track all of the numbers as well and reasons for referral, which is very helpful for us when we try to access more funding. You can move forward, Steph. Thank you.
Great.
So, actually, it's your.
Yeah, Neil, go ahead.
Yeah, it's your turn. Go ahead.
Great. Okay, so a little bit about our Bridges, because I mean, this is what we're saying the presentation is about. So we're going to speak a little bit about this process, because although we just say it's this meeting where people, kind of get together and help to decide the social prescription, there's actually quite a bit behind it and quite a bit around the history. So this was actually something that was developed at Seaway Valley in 2017. And at the time, we really did see some hesitancy from staff to refer internally to other health professionals as well as externally. So some people, there was perhaps a fear that their clients, they didn't know what was going to happen to the client, or there was potentially some trust issues where they're like, oh, I don't know, or they really kept the clients all for themselves. So and we have, as you can see with our earlier slides, with the complexity of our clients, people who have that many comorbidities, they also have, a lot of social issues. So a lot of our clients are chronically underhoused, or maybe in abusive situations. It's heavy. So these clients are really, really heavy to have on a caseload, whether you're a dietitian or a primary care provider or you're a volunteer, and you hear these stories. So the original way that Bridges was framed was really around if you're thinking about clients at night and they're keeping you up at night, you need to refer them to Bridges. If you're feeling like you're stuck with a client, refer them to Bridges. So that happened. So I had at that time, we had representation from management, and that's management actually from primary care and from community programs. So both managers. So the ability to make decisions and make things happen, escalate and advocate as needed was really important, because sometimes they were getting stuck because of systemic issues that needed some extra push to go forward. Health promotion, social work, and admin as well. And then, so that's kind of the core group. We have a core group of folks that attend every week, a nurse from primary care as well, volunteer coordinator, and then any staff is welcome to attend to present. So they can either just type in the referral, or they can also come and pop into the meeting and just present their case. We had weekly meetings to kind of to brainstorm and to kind of figure out these clients. And then there was a feedback loop with the provider. So our EMR, especially with the, before we were on Nightingale On Demand with NOD, now with PS, there's a really good mechanism that we were able to develop in order to loop back. So that's a little bit about the history, because that was 2017 and we're now 2023. So it does look a little different. And as you can see right now in this, in the way that it was originally formulated, it was quite deficit based. So looking at that as really, you know, a need or something that there's something missing, rather than really looking at some of the strengths of the clients. So as we've evolved throughout the years, we've really seen some of the outcomes or goals of Bridges to do is really to help with that care coordination. So sometimes it's just around logistics, around getting people from one team together to help coordinate. And we have this client and it's kind of messy, and like, can we set up a case conference, or what do you think? Or like, what's your opinion on this? There's also a lot of system navigation that happens, and that can be through also kind of blended with social prescribing or really straight system navigation. Then there's a social prescribing where we really look at what matters to you, that more upstreaming, being able to bring, you know, the client's strengths out, and really linking them with different resources in the community. It's a strengths-based approach. So we did do strength-based training, a lot of it at some points with staff, to really focus on finding the strengths, because in the beginning, people really came and it was really negative, because some of these clients, like we mentioned, they may have felt really heavy. So really, you know, really seeing the self-determination in clients, and that everyone has strengths and everyone has gifts, and how can we really pull those out? So that was a big part of this work. Something else is that it really helps to identify gaps internally and externally. So when you work with a group of people to kind of troubleshoot these different situations, you're also seeing like, oh my God, we don't have that here. That's like really something we need to do. Or, oh, externally, like this is really a gap in the community. So having that group of people thinking about it really helped. And then all of the referrals flow through the same pathway. So that's really nice. So we kind of get them all to come in. Sometimes some get resolved outside of the meeting if they're quicker. And yeah, some of them get resolved outside of the meeting. And then any referral that comes in, it's assigned or followed up by a staff. So that's really important. So it's like that idea of that most responsible provider. So even though you have the MRP, like the clinician, the referral that comes into Bridges is followed up by a staff. And so to make sure that that loop is closed, and maybe it is, I'll get more information and I'll report back. So it might be reporting back at the next meeting. And we also work heavily with students. So on the kind of lighter ones, on the lighter side, we're able to really involve our students. And sometimes when it's something that may need to go to, that may be a bit heavier, we may have someone else involved. But that is a big piece of it, is that really ensuring that each case is followed up by. Since 2019, with our new EMR to PS suites, there have been 753 referrals to Bridges. So it's quite a large volume.
Also, Steph, what I'd like to add is that when a staff member follows up on a referral, we also close the loop with whoever referred the client to Bridges, so that way they know it's taken care of and this person didn't fall through the cracks of the system. Great,
thanks, Chantal. And I think there's a question around, can you share what you use for strength-based training? Chantal, you probably have that info. We can dig it up in a bit. I can see if I can find the info.
Yeah, it was, some of it was a few years ago. However, even like some more of our recent trainings in terms of like CAPSA with Stigma Ends With Me when it comes to substance health and so on and so forth, I find that those specific ones are very helpful in terms of strength-based training. But yes, we can look that up and share it as needed.
How long, and there's another question, how long does a client normally stay supported by Bridges?
Depends on the request. It depends on the ask. Sometimes if they're referred to me as a social worker and I take that client on my caseload, it can be longer. If it's just like a one-off question, sometimes it's open and closed very quickly. Like I said, it all depends on the question or the ask. Sometimes it's referred to our PCO program, which is our primary care outreach for over the age of 65, and it may take a few months. It all depends on the ask.
Great. And what happens too is that we do see clients that are re-referred to Bridges. So because the acuity, or, you know, people navigate through life and have different situations that may arise, or different, they may be referred for one thing, we link them up with some supports, something may happen, you know, there may be a death, or they may develop new interests, or something may happen. So you do see referrals that could come back for the same person. And then that's addressed completely differently, right? So we would look at that as a unique kind of situation. We always have access to the previous chart, like it's all documenting, so we can see what's been done historically, which is really helpful for us because, you know, just knowing in terms of how to engage with clients, to best support them, and through motivational interviewing, you know, like, oh, you told us that you had this interest in the past and we linked you up, but it doesn't seem like that worked out. Tell us a bit more about that. So having that dialogue with them has been really helpful. I'm going to go to the next slide. I think it's over to you, Chantal.
Thank you. Okay, so Bridges, why it works for social prescribing. Well, like it was mentioned before, we've been doing Bridges since, we said, I think 2017. And it was a really, really easy way to just combine both practices because we were already doing it anyway. We just had to formalize the approach a little bit better. So Seaway Valley offers many programs and services to support Seaway Valley clients, and not just internally, but also community partners do as well. So it really wouldn't be fair to expect the providers to know all the programs and services and how to make all those referrals and so on and so forth for all of our clients. So myself as a social worker, and then other care, the nursing and health workers, it's mostly our responsibility to make sure that we know what the services in the community are and how to link them. So we're doing that work, and overall it's better for both us and for the providers to know exactly role clarity. It gives us role clarity, which is really great in terms of the staff wellness. Seaway Valley also has a robust volunteer program, which is very, very helpful. Sometimes we have volunteers call the clients regarding certain things related to other programming. Let's say, for example, like Powerful Tools for Caregivers, or even my program, Emotions in Me. What they will do is that they'll call and just confirm with the client that they're coming to their appointments. And the volunteers do so much at Seaway Valley, screening and so on and so forth. It's really great. We'll talk a little bit more about that later. But again, that's the way we can connect clients, because if they're socially isolated, they're looking for something to do, something meaningful, and that's what matters to them. We can help to onboard them in our programs. Next, we have Seaway Valley consistently has students support its work and often assigned to support Bridges. So we've been having a lot of social service worker students come through, and they've been very helpful. So as Stephanie mentioned, the lighter asks or questions, or let's say we need to research something, we'll have the students help out with that. And it's a great learning process for them, and it's meaningful for us and the clients as well. And lastly, everything is being tracked through our EMR PS suites, which, as Stephanie mentioned, is very helpful. So we know where we're at, and we know just how many referrals we have and how many clients we have to review when, let's say, we didn't finish all the clients or close all the clients from the week before. So it's helpful from everyone to know what everybody's doing on the same page. So this is something that's new here, our pathway. We actually just did this in the past 6 months or so, and we did it for funding purposes. As I said, we're already doing this work. We're just formalizing it, including our inclusion and exclusion criteria for Bridges. We're not going to go through it in detail today, but we just thought it was important to show you what we are doing and what that might look like in a graph format. Stephanie, do you have anything to add to this slide?
No, I think it was really a great exercise for us. This is we were able to do this over with a master's level student as well, and engage the student around like what does it look like when someone navigates through, and like how, and really articulate it, because this has been a big challenge. We've been doing this great work and we weren't really articulating. So for us, this is the first time we actually speak about this model, and this was the first time that we kind of had it written down. So that's great. Chantel, there is a question that I'm just going to address. Is that okay? Quickly?
Sure.
Yeah. So so the first one is history the only reason why you use bridges versus using link workers to supplement your work? Great question.
Yeah.
So, yeah. So we don't have any funding or funded positions for a link worker, and we don't really have, we're pretty small in terms of some of the centers. So our community development health promotion team is not huge. So this is why we don't really just have that opportunity to do the link worker. So that is a reason, and we talk a little bit more about it. So if we were given sustained funding, like funding to those that are, base funding, recurrent funding, we would definitely, I think, use a combination of those models and definitely approach the link worker model. The fear that we have is using, because we've had it a few times, especially a few years ago, those who've been around for a little while, with health links and system navigation around that, we would often get short-term funding. And what we found was that it was great whenever someone was in that role, but short term, there was sometimes we didn't want that piece to fall off. So it's a role that we're absolutely advocating. Every funding application, we have that kind of system navigator person or link worker in there. We just were not funded for that position. So this is our workaround. And what we'll speak to as well is it's a workaround, but also we think that there's a lot of value in this. And yes, absolutely, I can share this in a bigger format. Yeah, absolutely.
So these are some pictures here about some of our group programs and volunteers that like to help out. So as you can see here, we have, I think this was one of our social drop-in programs actually. And also one of our programs, our exercise programs. So these are just a few examples of programs that we can refer clients to internally. Some other things that we've used social prescribing for, some other examples could be we've bought Zumba passes for someone to go do Zumba. I remember one of them being a client who was actually a victim of domestic violence, and going to Zumba was a place where she can go to get out of the house and have her own space, and that was very beneficial for her. There was another one where we have I guess you could say this farm of rescue animals, and that was really good for one client to go to as well. She was able to attend the day program there, which is also very beneficial for mental health and make connections, not just with animals, but also with people, and potentially volunteer opportunities later on at the farm. We've given out swimming passes for the general public at the pool, but also for those who are more disease specific. So for those who struggle with fibromyalgia, there are specific pool passes for them as well to be part of a program. We've given money so people can buy art supplies, or gift cards, I should say, for art supplies. We've done social prescribing for running shoes, helped to encourage people engaging in volunteering. And we've also used bridges for help with filling out forms and providing the warm handoff with other agencies as well. So these are just like a few pictures, and we'll have more down the road, but just to give you all some examples of what we're doing with social prescribing and the bridges model combined. Here we have some more pictures here of other programs that we have with our clients. You'll see this lovely individual here in the middle with the LGBTQ flag. So she's actually a queer older woman, and she was the person who actually started our LGBTQ over 18 or all ages program back in 2012. She saw that there was a need for it, and together with discussing with her and talking with her, we did develop programs to further support this population. She even did some fundraising for that program, and we helped her in finishing her high school diploma, which is really fantastic. So she's thriving. I often see her at the center all the time, and it's lovely to see her. She's doing very well. And as you can see, this is just a great example of how Seaway Valley has been doing this work for a long time, well before social prescribing, but now we have a more formalized process. So again, here we have some pictures of our exercise programs and also of one of our staff members, Linda. She's showing her community garden, which is a lot of work, and she does a great job with it. We're all very fortunate to have her on our team.
Great. I have a question, Chantal, just around someone asking around what do you call that budget line when you give out individual passes? Okay, thank you. Thank you, Nedzia, for that question. I wish it was simple. Okay, so we were fortunate that we did get some funding through the Alliance or through the Public Health Agency of Canada for this specific project. So right now, that's the funding that we're utilizing is through this grant to support these clients with those specific needs. We tag it under client supports under our health promotion community development budget most of the time. So within our kind of, and I believe you're from a health center, so that would make sense within our kind of our buckets. But how we also support this is we get small amounts of donations, which I track so that I know, like I can, because a lot of them, they're coming specifically from people who really want to give back to some of these programs. Our community gardens actually is something that, you know, people love to fund the community garden. So we're making sure that there's a bit of sustainability around some of those pieces, but also with that the donations are able to support. Because as you know, CHCs are chronically underfunded. We haven't had any like increase to base operational funds. So it is really a challenge, but we're committed to this work and we do try to do the best. Just a quick note around some of the social prescribing is that, you know, whenever we were going in and we had this funding, we were kind of looking at, well, what we might need and like this and that. Swimming has been so popular. I swim. So I was like, oh, like I'm not surprised, but I am just so surprised and just the different varieties. So that's been really interesting as well, just for future planning as well. And but that one's really been big. And then just seeing the different, you know, aqua fitness, the drop-ins, the fibromyalgia swimming that's available, all of those different options. So that's been great. Sorry, Chantal, I'll let you go ahead.
No, that's good. Next slide. So here we do have a couple more pictures. One here is of someone, she's a volunteer and she's a screener at the front. So as you know, with COVID, we all needed some active screening. This is actually something we've implemented and maintained even after a lot of people decided not to do the screening. Although I think we've gone back and now we're doing screening again. But either way, I think this is something as part of a program that we have and that we're going to continue to do, whether or not screening is something that the regions will be doing, because it's really helpful to have that additional face right at the front where they can support people. We've had one person come in and I was a newcomer asking if they could get help ordering a pizza because they couldn't speak English. That was one just random example, but yes, we have a lot of random requests that just come in at the front, and even just to pick up forms or sign forms and so on and so forth. So having that additional face right at the front where we have a volunteer help out these clients and get the staff that's needed for certain situations is very helpful. So we really do love having our volunteers here. They're quite a great help. And then next picture, we have also Linda again here with Beth, who we kindly call her Mama Beth here at Seaway Valley. And she's a robust volunteer. She's actually a client and she's also on our board. So we felt it was very important to include her, as she's very much part of the Seaway Valley and has that spirit that we all like to see. So some of the examples of things that would prompting questions that we would ask clients when we're doing social prescribing or when we're meeting with a client after getting that initial Bridges referral is things like, what matters to you? What do you enjoy doing? What does a regular day looks like for you? Have there been times where you felt lonely or isolated? Can you tell me more about it? And some other questions addressing more of the social determinants of health regarding food and housing and accessing care. So we try to focus on all the social determinants of health to make sure we're not missing anything. And most of the times when you give a client a space to speak, they will tell you what's happening, and they're quite grateful of being given a space to, non-judgmentally, to share about what they're going through.
Great, thanks, Chantal. I do have a question here that I'm going to answer. Have you considered training volunteers for the link worker position? So a little bit about us at Seaway Valley. So we do have close to 50 volunteers at the center, which is larger than our staff complement. So we do have a very large, robust volunteer services program. And they have supported Bridges. So they do support the social prescribing and the Bridges work. Specifically during the pandemic, some of our volunteers were really instrumental in doing well-being calls, like social, like check-in calls. So they were actively involved in that. And they may be involved in terms of once the referral has been done, and there might be some linking, like, you know, if there's a volunteer actively involved, something we may say, like, is it okay? And we've had a conversation with the client, like, is it okay? Do you want to speak to one of the volunteers about this opportunity, or they may know something? Can we connect them? The tricky piece, I think, for us around getting a volunteer, because a volunteer as a link worker would be just the amount of personal health information and navigating that whole piece through the way that we're through our current process with a volunteer, because the risk of being in the chart and making those errors and being able, so that would really have to be looked at really closely. And then as well, like, we have to make sure that we're not using volunteers for work that should be done by paid staff. So that, but they are incorporated, but just not formally, but it's just definitely something you could explore. Okay, I have another question around what resource databases do you use, if any, to identify and refer community resources? So the advantage of having an interdisciplinary team is the wealth of knowledge that we have around the table. So that is, I think, like, the number one advantage is that we are basically a resource book in front of you whenever you look at the different people. That being said, we have we do use 211. There have been resources that have been developed locally as well. So we would use those. We've also created internal resource books. So when we have students, that's always a task that we get them to do, is kind of update the resources. So anything that we have, so we use a combination of the provincial, kind of the 211, as well as those, we have some city ones or municipality ones for organizations that are around here, and then just the knowledge that we have. And a big thing around this Bridges as well, and again, with the students, is just calling up, making sure the information is accurate as well. So that's a big piece of it. But yeah, that is definitely the big challenge is, knowing what's out there. And I think that's why the group is so helpful. And whenever, there's never a loss of organizational knowledge, because say we are fortunate enough that we don't have a lot of staff turnover, but if we did, it would be, one person out of 7 at a table, so that, there's still a lot of organizational memory at Bridges that's able to support the clients. So some of the key elements that we've seen in Bridges' success has been communication that's been ongoing. So I think, as Chantal was saying, we really make sure to close the loop with the provider. We're talking to the client. We're always able to just always have that dialogue. And it's kind of like looping in with the second one, but that's really built a lot of trust with the staff. So we're close to, I want to say we're at that within the primary care, so nurse practitioners, physicians, and then allied health as well. I'm going to say that we're at 100% participation in terms of people that would refer over to Bridges. So that's great. That was not the case in 2017. In 2017, we really struggled to get people to refer. And I think I'm going into my next one, the pandemic did actually help to really bridge the gap between primary care and community, and the support that's needed for that. So that's been really helpful. The other piece that's been really helpful is the management support for time commitment. So, we're okay. I'm one of the managers, and I'm saying, yes, this is important. Go to these Bridges meetings, even if it takes away from clinical time. So that's been really, really great.
Can I add something here, Steph?
Sure.
I just want to add to the point of trust between team members that the pandemic, yes, I agree, did help. But also I found that helped is that once we started telling people that there's no rules when it comes to referring to Bridges, like if you're like, oh, this was supposed to be a social work referral, not a Bridges referral. This was supposed to be a dietitian's referral, not a Bridges referral. There's none of that. Even if it gets directed to Bridges, we're still going to route it to where it needs to go. And I feel like the providers really appreciated that, because then they know that there wasn't any quote unquote consequences, that they didn't do the wrong thing. That really Bridges is a yes to anybody for any request. And that really helped to increase our referral intake.
Great. So, yeah, so one other piece is that the ongoing and strong client and community advocacy. So we're really able to advocate for our clients, advocate to different organizations if they're not moving through the pathway as they should be, and helping, whenever you're like, this is happening, and then someone else is, and so you may be doing the work with the client, you may refer them because you feel stuck, and then we're like, no, that's not right, this should be this, and then you're having a group of people that are supporting you with that, with moving that client forward. And then the willingness of staff to think outside the box. So, I mean, we have come up with creative solutions, and that's been great, all within the confines of our policies and procedures, obviously, but really looking at how we can best support our clients. I'm going to go to the next slide. I do see a question, but I'm going to come back to it later if that's okay, Chantal. I'll let you go ahead. I think I have, yeah.
So I'll try to be quick here so we can get to the questions. So we recently, actually yesterday, had a meeting and we asked them, share in one word how Bridges or social prescribing has supported you. And here are some of the answers that was provided. As you can see here, the answers here, they all kind of directly correlate to staff and employee wellness. When you have collaboration, they feel less stressed, they have some relief, they have moral support, they feel supported. So I really do think that the unintended positive consequence of all of this is that it really helps in terms of staff wellness and wanting to come to work and just not feeling so overwhelmed and decreasing the chance of burnout. So Bridges versus a link worker. I think this is a great slide here. So the advantage of having a link worker, yes, it would allow for less extra work from Bridges participants, myself included. I wouldn't have to do as much. And the link worker would be able to dedicate more time as needed versus having more on my caseload. However, the disadvantage of that is that we risk a knowledge gap if someone were to leave a position, and then I would have to take on that client anyway. And then there's no longer any shared responsibility of the client. So what I like about the Bridges model versus the link worker is that a lot of times we'll get a referral and we'll have somebody, like we said, we don't have a lot of staff turnover. So we'll have somebody say, oh, I know this client. I remember this client. I have a great rapport with this client. Or like, I just saw this client yesterday, or this client is already referred to me by somebody else. So to have that shared responsibility of the client is, in my opinion, professionally and personally, a much better model of care for the client than just having one link worker who works alone and who has the expectation to network with everybody else. I think this way it's much better. We have about 1 minute left. So just to really quickly going over the slide with the advantages of a Bridges model is that there's less risk of knowledge loss, like we mentioned. There's shared ownership and greater ownership. There's ongoing brainstorm no matter what, because there's always new information coming up in the community, ongoing student opportunity, and improved collaboration. We'll go to the challenges real quickly. So it is an added workload. There is a time commitment. We do require buy-in from managers to help with this process because we do need them there at the meeting to help us move through and push some of the things that aren't moving. We do rely on students, and there is change management required for new initiatives, some quality improvement things, and capacity could be an issue in the future. Steph, you want to take this one?
Just quickly, our current model could be improved by sustained funding to support this. So if we, for all the extras, we talked about those extras and how we're scrapping that together. So if we did have sustained funding, that would be possible. That would be helpful. One thing we followed with, we've struggled with as well is just the follow-up. So once they've had a social prescription, so we're working on that right now, 6 months down the road, a year down the road, how do you close that loop and see the value? What we see is that sometimes it's not 6 months down the road or a year, it's a few years. Consistency with tracking. So again, this is something we've improved, but we used to get kind of like these organic social prescriptions that wouldn't be tracked through the EMR. So that's been something that we've been working on. And then base funding for additional support. So really one of the reasons we don't have that link worker model is that we don't have funding for a position. And so a little bit to the question above is that we actually haven't put out the qualifications needed because it's never a position that we've had. We've had a system navigator, but it was more through a health links model. So we've never had that opportunity to actually hire for that position. And I think that is it for us. And I think we're over time. We thought we were going to have not enough. We were going to have a lot of dead air time. So I don't know if people have to leave. If you have any questions, you can always email. I don't think my email is actually there. I can pop it in the chat. Actually, if anyone has questions, I will pop that in the chat. So just feel free to email me with any questions that you have around the model, how it's gone. I mean, it's been a work in progress, not perfect, but we think it's a nice alternative, especially as we know some people do have that kind of shorter term funding for social prescribing and what it can look like for sustainability. Great, thanks. And thank you, Chantal, for co-presenting with me last minute or fairly last minute.
No problem, it was my pleasure.
Thank you both for such a wonderful presentation. If anyone is looking to, you can also message on the conference platform as well for any follow-up. Thank you both.
We're talkers.
No, it was wonderful. Thank you so much. What a great walkthrough. Thank you.
Thank you.